Hello, my name is Michael O'Toole. I am a DNP student at Fairfield University, focusing on the psychiatric concentration. I work full time at the U.S. Department of Veterans Affairs at the VA hospital in West Haven on a 12-bed medical step-down unit, also a telemetry unit where we do lots of clinical training for Fairfield University undergraduates. Some of my leadership activities include one, being on the VA Nurse Academy Partnership Steering Committee, which is a group of members from both Fairfield University and the VA, which organize the VA Nurse Academy, which is a residency program that helps guide new talent into the workforce. And I am also on a data work group, which is comprised of members from the Department of Labor and also the Connecticut Nursing Collaborative Action Coalition. And what we do together is prepare for the analysis of the minimum data set, which was collected at the Department of Public Health. It is a variable questionnaire which assesses the supply of nurses across Connecticut by demographic, by region, and also discipline and education, very importantly. I have not decided on what my capstone project will be, although I have two ideas that I'm working on. One would be to use the minimum data set to account for the effectiveness of federal funding, whether it be Title VIII from HRSA, the Health Resource Service Administration, or the National Institute of Nursing Research, and how effectively that is being used in each congressional district to meet the needs of medically underserved populations. The other topic I'm interested in is just looking at quality measures at the hospital where I work, recidivism rates and length of stay, particularly with the mental health population. Well, enough about me. Let's move on. The title of this presentation is Effective Leadership as a DNP in the Future. We're going to talk about what the Doctorate of Nursing Practice is, what its origins are, how it was implemented, and its significance. The objectives: firstly, I'd like to provide a conceptual framework for effective DNP leadership. I chose the Donabedian Model, which is broken down into conceptual components described as domains of inquiry, the process, the outcome, and the structure, which I'll explain shortly when I present an article from the Journal of Nursing Administration. After that, I'd like to explain and answer the question, what is the DNP? How will you answer that question to stakeholders or when you are presented with patients and other clients? What are the origins? Again, how was it implemented? And what is the significance in the future, beyond healthcare reform, or perhaps an aging baby boomer population 100 years from now? How can we create a system that's adequate to care for exponentially increasing populations? Something sustainable. The Donabedian Model is broken down into what are called the healthcare process. I'd like to differentiate concepts such as terminal degree, advanced practice, entry-level degree, DNP, and PhD. Also, the campaigns for nurses on boards and this idea of secretary of the future and the nurse's role in legislation or government. The Donabedian Model refers to an outcome focus. This is the common cause of cost and quality in healthcare, and I'd like to speak to some of the opportunities for the Doctorate of Nursing Practice and how the evidence-based competency relates to outcomes, and perhaps suggest the magnet study as an example of how nursing leadership can affect change in this domain of healthcare in terms of outcome. Lastly, the structure focus, which deals with the supply and demand and how disciplines are utilized in the workforce. Also, the national assumptions and state level assumptions influencing the healthcare industry. Quickly, what the minimum data set and national sample surveys can tell us about the utilization of the Doctorate of Nursing Practice degree, which also relates to the consensus model and evolving practice rights. And lastly, healthcare reform, Title VIII, and medically underserved populations, what the role of the Doctorate of Nursing Practice might be in the future. Lastly, I'd like to put it all together and present a DNP leadership case example. Here we have an article from the Journal of Nursing Administration from 2014, conveniently featuring 3 doctorately prepared nurse leaders, the DNP APRN, the PhD RN, and EDD MSN. The article introduces the topic of DNP utilization in terms of IOM recommendations, which call for increased education levels across the nursing profession, both undergraduate and graduate nurses. However, more interestingly, the article features a survey which was developed based on Donabedian's conceptual model, which identifies 3 domains of inquiry. Again, the idea being that a healthcare leader, a DNP leader, can affect change most effectively by targeting these 3 domains of inquiry: the healthcare structure, the healthcare process, or the healthcare outcomes. For this survey, the structural elements included the type of DNP practice setting, including inpatient and outpatient. Perhaps the value of a DNP nurse leader may be relevant to their ability to serve patients in the outpatient communities, preventing them from being hospitalized, being sure that they're immunized, lowering risk factors, and in turn lowering costs of health and intensity of healthcare demand. The second element is the process, and those were identified in terms of APRNs, what they are in the workplace. Are they clinical nurse specialists? Are they certified nurse midwives? How are they defined? Now this hinges on the consensus model, where a certified RN anesthetist may be a CRNA in Connecticut, but a very different thing, as we'll learn later, in the state of Florida. And the cause for the DNP nurse leader in Florida is one very different, perhaps one where we in Connecticut take for granted our Practice Act when we learn of the efforts of those DNP leaders in Florida who are still trying to work on the healthcare process by defining their scope of practice. And then lastly, the identified domain is the outcome, and that is perhaps the most familiar to both the patient and provider, being that that's the reimbursement model that is also the magnet template. Now that we've explored the conceptual framework in the Donabedian model, some history in regards to the 2004 American Association of Colleges of Nursing statement that they were in full support of the Doctorate of Nursing Practice, which is distinguished from the Doctorate of Philosophy and the Doctorate of Nursing Science, which are both considered research-focused degrees, as opposed to the Doctorate of Nursing Practice, which is a clinical degree. But if you read this statement from 2004, you'll see that much of this effort to advance nursing education grew out of the Institute of Medicine's investigations in the reports To Err is Human, 1999, Crossing the Quality Chasm, which was chiefly concerned with the aging population in 2001, which continues to be a major concern, and also the Health Professions Education, A Bridge to Quality 2003 report, which states that all health professionals should be educated to deliver patient-centered care as members of an interdisciplinary team, emphasizing evidence-based practice, quality improvement approaches, and informatics. And there's the future that is now here for the DNP to contend with. In 2006, the AACN began to implement the DNP by recommending 8 essentials of doctoral education for advanced nursing practice. Here they are, and again, number 3 being clinical scholarship and analytical methods of evidence-based practice, what makes the DNP unique from the PhD research degree is this practice-focused research that occurs in the clinical environment. The competency of evidence-based practice allows the DNP nurse leader to institute change systemically, either through informatics or quality improvement initiatives. The Doctorate of Nursing Practice, the DNP, was not entirely adopted across all disciplines until the American Association of Nurse Anesthetists, after conducting a 2-year high-level task force summit to thoroughly explore the interests and concerns surrounding the doctoral preparation of nurse anesthetists, agreed that for CRNAs to be best positioned in an ever-expanding healthcare industry, that they require the doctoral of nursing practice as entry level. And I just want to remind everybody that it was less than 10 years prior that in 1998, the discipline of nurse anesthesia graduated to the master's designation. So less than 10 years since then, we're advancing all practice to the doctorate of nursing practice. It's a very familiar topic. So the discipline of anesthesia was right in conducting a 2-year review. That being said, the statement was made in June 2nd, 2007, and this really solidified the implementation of the DNP in nursing education across the nation. When we consider the significance of implementing a systemic change, such as introducing the doctorate of nursing practice to the healthcare system, it's essential to know the greater workforce and to be able to measure the impact of utilization of the DNP. And this graphic partly tells the significance of advanced practice nursing, but to a lesser degree, it does not tell the doctorate of nursing practice story. So it shows that we have 62,000 registered nurses in Connecticut and 4,200 approximately of which are advanced practice nurses. But we do not know how many are truly master's prepared versus doctorately prepared. We do know roughly those that are working in independent practice and those that are employed by greater institutions. But in order to measure the effectiveness of DNPs versus MSNs, we need to more precisely understand the variables in the workforce. It's hard for a DNP nurse leader to advocate for the DNP's effectiveness if we aren't sure of how many of them are serving what populations. And the minimum data set, which is collected at the Department of Public Health, this year being the first complete data set collected, allows for a baseline picture of where DNPs and how they are being utilized. I'd like to pause and consider this discussion question in the micro groups. How are the roles of the DNP and physician assistant juxtaposed in the primary care setting? How are they similar and how are they different? How can they both be effectively utilized across the healthcare system? The doctor of nursing practice leader should know there are opponents to the very existence of the DNP. This article here, published in 2008 in Medscape Journal of Medicine, the doctor of nursing practice, recognizing a need or graying the line between doctor and nurse. The abstract states the distinction between doctor and nurse has historically been visible to patients. The scope of practice for each healthcare provider has been clearly marked by a wall of separation rooted in state law. In fact, even the titles by which these providers have been addressed have remained constant, with the term, quote, doctor being reserved for reference to physicians. With the advent of the new Doctor of Nursing Practice degree, however, the clear distinction between doctor and nurse is in jeopardy. The article further um, suggests, considering the level of qualification of today's medical school applicants, perhaps we being trained more physicians to meet the demand head on rather than creating a separate practice doctorate to fill the gaps. I found that quite interesting. But nurse leaders know that our position of leadership is above and beyond being that of an assistant to a physician. The National Organization of Nurse Practitioner Faculties echoes the sentiments expressed by the AACN and the need for doctorately prepared nurse leaders to meet faculty shortages. Um, in this document from 2015, the National Organization of Nurse Practitioner Faculties Board of Directors reaffirms in April 2015 an allegiance to advancing the Doctorate of Nursing Practice degree as entry level for the nurse practitioner role. This is significant because currently there are more master's prepared nurse practitioners functioning throughout the state of Connecticut than there are doctorately prepared nurse practitioners. It should also be noted that since before the 2014 statement by the AACN in regards to advancing nursing practice to the doctorate level, the National Organization of Nurse Practitioner Faculties was in support of that advancement as well. But the question remains, where do the institutions stand on the advancement of education? This is a report from the Department of Labor, again, the Allied Health Workforce Policy Board from 2015, which features Fairfield University as one of its significant healthcare initiatives, stating that Fairfield University, down here, at the master's level, there are 3 program options: Master's in Nursing Leadership, Family Nurse Practitioner, and Psychiatric Mental Health Nurse Practitioner. In September 2010, Fairfield University launched its newest nursing program, the Doctorate of Nursing Practice, and in May of 2013 graduated the first 5 candidates. In 2014, Fairfield University awarded 30 DNP degrees. The DNP is a clinical doctorate in an advanced specialty of nursing practice and is comparable to clinical doctorates in other health disciplines such as pharmacy, physical therapy, and medicine. I would also say education. With a DNP, nurses can assume leadership roles in an increasingly complex healthcare system during this critical era of healthcare reform. I couldn't have said it better myself. Where does another neighboring school stand on this issue? Well, this is the AACN database of the 240 schools nationwide which offer a DNP degree. And as you see here, Yale University is offering only an MSN to DNP. So that means they still value the MSN preparation as a practitioner level degree to some capacity, requiring that, not offering, for example, the BSN to DNP, which Fairfield offers. Apparently a prerequisite is that you either function as a nurse leader, clinical nurse leader, or a existing advanced practice nurse at this time. I'd like to pause again and Discuss question number 2 in the micro groups. Should there continue to be MSN programs? And if so, what role can you foresee them fulfilling? The AACN asks the same question: will master's level nursing still exist? Should these programs be phased out? And they reply, yes, master's education will continue. And they cite the Clinical Nurse Leader, a national demonstration project launched to introduce a new master's level role into the healthcare system, is one model of master's education. Also of note on this page, the AACN responds to the question of opportunity for tenure uh, between the DNP and the PhD. And they cite that data shows in 2001 that doctoral students who also teach are just as likely to have a DNP as a PhD. This indicates that graduates of both types of doctoral programs are finding teaching positions. Another role for the DNP nurse leader might be sitting on a nursing board. This is the Connecticut League of Nursing's website, and they are championing a campaign to be counted among 10,000 nurses who sit on boards by 2020. And this is how one can be a DNP leader and be an expert consultant affecting change across the healthcare system. And how might they do that? Again, the common cause of cost and quality. This document responds directly. It's a compilation of research studies that show the cost effectiveness of the nurse practitioner role. Nurse practitioners are cost effective in many ways to many degrees. The more obvious way of saving monies perhaps would be in terms of salary, where the median total compensation for primary care physicians ranged from $208K to $219K depending on discipline, whether family or internal medicine, compared to the nurse practitioner's total salary of $97K. This translates to a significant sum of money across numerous practices that are caring for millions of people. The nurse practitioner, however, is cost effective to a greater degree in that, based on a systematic review of 37 studies, Newhouse found consistent evidence that cost-related outcomes such as length of stay, emergency visits, and hospitalizations for nurse practitioner care are equivalent to those of physicians. Now, this is greatly significant because today, as the American Hospital Association knows, all payment is linked to quality. And here are the terms for pay for performance. The AHA supports the general concept of linking hospital payments to meeting performance targets on quality measures. However, they are very concerned that many of the quality measures upon which federal pay for performance programs are based do not produce accurate performance results, making them inappropriate to use for public reporting and accountability programs. And this is one of those assumptions that is inherent to the system that nursing leadership is most apt to change, especially that of the doctorate of nursing practice leadership. Where do they stand in terms of accountability for quality and how that is linked to payment? Someone who really embodies the role of nurse leader and was able to affect change really across all of the identified domains of inquiry in the conceptual model, the Donabedian conceptual model, is Dr. Margaret McClure. She's right here, and I met her in Washington, D.C. at a nurse leadership conference, and she is famous for utilizing the evidence-based practice model to really push forward the nursing profession. And what I mean by that is she was involved in creating the 1985 BSN to entry into practice proposal. But even more famously, she co-authored the groundbreaking study, Magnet Hospitals, Attraction and Retention of Professional Nurses, going on to serve a 3-year term on the Commission for Magnet Hospitals, which established the magnet standards and criteria. So again, emphasizing the use of evidence-based practice. Listen to how great she is. Quote, "The Magnet Hospital program has pushed us to develop evidence-based practice and nursing research, and like a rising tide, it has raised everyone's practice and standards." Now that is an effective doctorate leader that is affecting change across the inquiry domains, across the entire conceptual model of healthcare. Before we conclude with the DNP case study example, I'd like to ask the microgroups to discuss this question. Should DNP FNPs be encouraged to manage mental health issues and prescribe psychotropic medications independently? Or is it better to encourage referral for mental health issues to a psychiatric mental health nurse practitioner? What factors might influence the healthcare structure, process, and outcomes? Quickly, before we conclude, I'd like to present the DNP nurse leader case study, who is Ms. Lori Shirley, someone I met at a leadership conference in Washington, D.C. Not only does she know all of the finest restaurants in Washington, D.C., she has been a CRNA for 9 years and is very interested in healthcare policy and serves as president of the Florida Association of Nurse Anesthetists, also federal political director of the Florida Association of Nurse Anesthetists, and is currently on the Florida Action Coalition tasked with implementing the IOM Future of Nursing Report recommendations in Florida. And Florida is not as progressive as Connecticut regarding the consensus model. As you can see here, in terms of independent practice and independent prescribing in the consensus model, Florida ranks poorly. In fact, only 12 across the entire consensus model, ranking 0 in both independent practice and independent prescribing. It has been Lori Shirley's efforts to convince medical entities, associations, institutions, etc., and also drug and pharmacological interests that nurses are responsible prescribers. Thus, she conducted a research study here, which looks at state variation in opioid and benzodiazepine prescriptions between independent and non-independent advanced practice registered nurse prescribing states. So, she is building an argument using evidence-based practice to determine if the fear of opioid epidemics being linked to nurse practitioners is valid. And thus the study, which is quite comprehensive, finally concluding that no, nurse practitioners are as responsible, if not more responsible, in their prescribing practices in terms of opioid and dependency than medical doctors. So this is an example of how one nurse leader is using the evidence-based practice competency to affect systemic change in her state government and also in her profession of nursing through the healthcare process, defining and advocating for her consensus model and the scope of practice, her prescribing rights. This will change healthcare assumptions within the state and ultimately affect outcomes and also the greater structure of healthcare. She's been a great mentor to me, and I've learned a lot about not only the healthcare system in Connecticut, but also nationally.